Hi everyone, Tom here from Diabetes Chat. How is it going? Welcome along to our Diabetes Chat research event. This is our fourth research event that we have hosted, and we are looking forward to sharing with you tonight lots of different research projects and innovations. So let's have a look. You can get involved on our website, diabeteschat.net, on our social medias, Twitter, YouTube, and Instagram. So welcome along to our research event. We are live till 10 o'clock tonight, and we'll be sharing 7 different research projects. And it's going to be really, really fascinating to hear and learn about different projects coming up and how you can maybe get involved. So let's have a look. What is coming up tonight on our research event? We have 7 guest speakers, and before that, we'll be speaking to Kes and Stephen, who'll be sharing their lived experience perspective of participating in research. Then we will have our 7 speakers. So we have Dr. Amar Puttanna, who will be talking tonight about dementia, which will be really fascinating to hear. We did have a diabetes chat last year with Amar, and tonight we'll be talking more about that. We have Dr. Tom Crabtree, who will be sharing research on the hybrid closed loop pilot study. Dr. Lauren Quinn will be sharing the ELSA study, which is a UK program for children aged 3 to 13 in T1D screening. So check that out later on. James Ridgeway will be talking about a newly funded project at the Eden Centre in Leicester on peer support. So we'll learn about that later on. Glab will be here from the Leicester Diabetes Centre, and we'll be talking about different research projects, including sleep, foot care, and hypoglycemia. Rebecca Thomas will be talking about eye screening and health. And to finish our night, Rachel Hicks from Australia will be joining us, and she will be talking about pregnancy and peer support. So, welcome along. We hope that everyone is enjoying the evening so far, and you can use the hashtag diabetes chat, and you can post in the chat box and join the chat on our website where people are tuned in, and let us know where you're listening from, who you are, your connection with diabetes, and we'll get them up to the screen and share it with the community. So what we're going to do is we're going to bring up Kes. Hello, Kes.
Hi.
And Stephen, hopefully. Hello, Stephen.
Hello.
How are we all? How are you both?
All right, I might even put my camera on.
Why not? Spoilers with this. How are you
I know.
both?
I'm all right.
Good, good. Well, welcome along to tonight. And like I said, what we're going to do to kick start our chat tonight is talking to you guys who live with diabetes, have a connection to diabetes. So before we obviously go through some questions on research, do you want to introduce yourselves of who you are, your connection to diabetes, how long you've had diabetes, and why not, let's throw it in, what technology are you using to check your levels and administer your insulin? What are you using? Go on, Kes.
Go on, Kes.
Yeah, I mean, I think I'm fairly newbie still, really. I was diagnosed in 2019, after a long period of misdiagnosis. So diagnosed type 1 as an adult. And I closed looping for about a year now, just over a year. 780G and Guardian 4.
Brilliant, brilliant.
Cool.
And what about you, Stephen?
Well, I was originally diagnosed on the 20th of February 2014. So about a year, a week tomorrow. And I was misdiagnosed. I was diagnosed as type 2 originally. Turns out that I wasn't, badly, because I had it for 5 years by going pretty much low carb and everything else. And then I had a doctor look at me and go, I think I better take another blood test from you. Did antibody check, May the 15th, 2019. That's when I was re-diagnosed as type 1. Currently on self-funding Dexcom and looping with the T-Slim, tandem T-Slim. I've only been on that since September. So it's all good.
Yeah, and also you're a parent with someone who has type 1 as well, aren't you?
Yeah, Lewis has got type 1. So we've had type 1 in the family. My gran, so I grew up with type 1 because my gran had, she was diagnosed way before even my dad was born. So you could say that insulin's the reason why we're here. So, but yeah, that was, she was diagnosed like late 1940s. So I knew about everything about it, and obviously I panicked when I was first diagnosed because I can see I've seen all the bad things that can happen, and I was making damn sure that I didn't have to go through all that, and make sure that Lewis doesn't either. So, but Lewis
Yeah,
is 10 years old. He's looping on the 780G as well, same as you guys, and it's brilliant, superb. It's an absolute game changer.
brilliant, brilliant. We've got loads of people joining. A few I'll shout. Some people: Leah, Marley, Anne-Marie, Hammy on Instagram are tuned in. We've got people also, Rob, and many other people on our YouTube channel and our website. So welcome along. Mark also tuned in as well. So obviously tonight we're talking about research, and that's why we're here at tonight's event to talk about diabetes research. We've got 7 fantastic talks coming up, 15-minute chats talking to people who'll be sharing their diabetes research. You guys obviously are representing the lived experience perspective. Before we start tonight, so let's a few questions for you is, how did you get involved in the diabetes research, and why did you get involved in it? And maybe tell us a little bit about that specific research that you were involved with. Should we start with you, Stephen?
Yeah. So, well, I was invited to do a study for long COVID. I've not had long COVID, but I did have COVID during the pandemic, and it was put at me by I'm sure it was the hospital. I'm sure it was the Western, the hospital I'm in. So obviously Edinburgh's got a couple of centres, and I saw the study. Do you want to take part in it? I said yes. Took part in it. So it's long COVID study and the impact for those with type 1. Basically, all they did is they take you in. Last year, did your usual HbA1c, your liver functions, your weight, and then did a couple of other things, your lung capacity test, strength and your grip, things like that, body fat analysis, and also a beep test. So in other words, that one that you always hated doing whenever you go to somebody goes, right, we're going to do the beep test. You go, no, it's big old radio, just going beep every minute or so, and you've got to run each end of it. And it
Brings back
did that.
P lessons that back in the day.
PE lessons and painful nights at Cubs when I was growing up. And then basically that goes on your record, and then they bring you back a year later just to see whether anything has changed. And that was only just completed in November, which was interesting. Over the year, nothing really did. Well, they said that my body mass had actually increased, but I'd lost fat, which is good, which is quite a surprise because it was not active at all last year. And just recorded HbA1c, lung capacity again, and they give you the results straight away. They actually tell you this is what you've got, this is how you've improved, which I thought was quite good. And I could tell, and I know a few others that have actually done that. They've done that session, and to be honest, they found it really interesting because it's basically to see whether there is an impact for person with diabetes because of COVID, and whether there are long-term effects. Luckily for me, it looks like there isn't, which is great. I know people that have been affected by long COVID, so either with or without diabetes, so I was more than happy to help. But while I was there, Life Scans they're like another sort of research team it's a commercial research team. They're basically checking or trying to test different versions of diabetes test strips. So blood test strips, blood glucose test strips. And that's actually based at the hospital, which is the Edinburgh Royal Infirmary, that my study was at. So, and they said, come on in, have a chat and everything else. And what they do is they just call you in when they've got a new study or everything else, get you to do a finger prick, they basically take enough blood to load about 18 different blood glucose meters, and then they give you a wee bit of money, and that's it. You're on your way. And then they went, bring your son in next time. So Lewis went in. He's too young, unfortunately. He's got to wait till he's 12. But
Yeah.
it was just a case of just seeing that what we are doing is potentially making a difference, whether it be for the healthcare system or whether it be for blood glucose monitoring, because some of the advances of doing the test strips is quite good. There was one where if you didn't put enough blood on it, you can take another drop and it can work, which is obviously something that we've all been there, whether it be blood glucose or ketone, getting as much blood on it as you can, and then all of a sudden it's saying E7 or E4 because you've not got enough blood on it. So everybody knows that. So yeah, it was quite good and interesting. So
wow, brilliant! It is great that you were part of them research studies. What about you then, Kes? We've got a couple of minutes before our first speaker. What did you get involved in, and why did you get involved in it? What sparked that interest for you?
I've done a couple. A lot of them were, to be honest, were local universities whose students were looking at initially emotional well-being and distress kind of type area. So I responded to them a lot. But the big one for me was the Steady project. I was lucky enough to be selected to actually be part of the program rather than the section that weren't involved. And that came about. I actually saw the advert go out on Twitter and applied to be part of the Tide research and to do that program, because in my area I was struggling a lot. I've spoken about it before. I don't make it a secret. And there is no diabetes psychology in my area, and anyone living with Tide, I would say, doesn't fit the criteria for the mental health support that is available in our area. So I was lucky. I went to King's, did all my initial screening with them, which included a full kind of mental health background, HbA1c. They've got access to all of my data and things like that. And then I did the program with a DSN, which was a game changer, to be fair. Not having to sit with someone and explain what type 1 is and how it impacts me day to day made a difference in how that worked and what we were able to focus on.
Yeah, absolutely. And just final question from the both of you: do you feel would you advocate for people to get involved in research studies, and is it something you both would be up for doing more of?
I think so, 100%. I've got, as I said, everybody knows that there is a genuine link for diabetes between families, certainly within my family, especially. And if there's anything I can do because of my diagnosis that will help somebody else in future, then I'm more than happy to help that out. And if there's anything, no matter how little it is, like for instance, I know that the 2 that I've done are non-invasive or whatever else, not a drug trial. I would always take second thoughts on a drug trial, but certainly for a lot of the other things and a lot of the research, I'm more than happy to help out, because I feel like we are walking experiments, so why not help that out?
100%.
So,
yeah. What about you, Kes? For sure.
Yeah, definitely. Pretty much anything really. I'd give it a go. There isn't a history in my family, so particularly for those who don't have a history or have, strangely enough, we both had the misdiagnosis, but
I know.
in that area, definitely.
Yeah, brilliant. Thank you so much, Kes and Stephen, for dropping in tonight and starting this fantastic research event, sharing your lived experiences. And yeah, please go check out Kes and Stephen on Twitter and social media. And if you have any questions for them, put them in the comments, and the guys might be able to answer them for you. So thank you, Stephen, and thank you, Kes.
Thank you.
So thank you, guys. What a fantastic way to start our research event today. Let's have a look at what we're going to do next. So we are going to have our first guest speaker, Dr. Amar Puttanna, who is from the West Midlands area. He is a diabetes and endocrine consultant. And tonight, Dr. Puttanna will be talking about dementia and frailty. And Amar has been a diabetes chat guest speaker previously, and it's an honor to have him tonight here to share some research on dementia. So welcome, Amar.
Hi, Tom. Hi, everyone. Good to see you all. Well, not see you all. I guess talk to you all again after probably about a year, actually, wasn't it?
It's been about a year, yeah. So obviously, it's great to have you. It's great to have you here this evening. So I will bring up your slides, and then if anyone has any questions or comments for Amar, pop it in the chats, and we'll bring them up to Amar later on. So over to you, Amar. Thank you so much.
Thank you. Right, everyone, we've got a kind of whistle-stop tour of all this. So I know last year I talked a little bit about frailty and dementia and cognitive impairment, and I guess it got a lot of interest, and I just wanted to kind of go back a bit to that to talk about it. I have a number of different roles, but I want to clarify that I'm here as purely Dr. Puttanna and myself, and that role as a doctor and as someone just trying to disseminate knowledge, nothing else. So I guess most of what you'll find is that there's a lot of different kinds of research. There's research where you have to actually get involved and take part in trials, as mentioned. And there's research where you can look at what's happening currently and what's going on based on looking at large amounts of data and what's available already. And this sometimes can lead to something called real world data. So this is where you look at what's happening currently, just based on, how many people are coming in with diabetes into a hospital, for example, or how many people with diabetes are treated with XYZ treatments, medications, or have a blood sugar of a certain level. So you can look and get a lot of kind of data looking at that to kind of analyze and say, well, what's happening currently? And where that's different from research trials is that in research trials, you usually create new knowledge where you say, let's intervene, let's do something, and then we'll measure what happens next. And that could be anything. It could be, having a Fitbit, could be having a medication, could be doing this app. So that's kind of traditional what you think research. But a lot of the research, I guess, for people who are kind of perhaps not as academically minded as myself, more clinically minded and more treating people, you really can do this kind of data where you look to see what's happening at the moment and guide what current practice is. And that's kind of what my research focused on, and predominantly type 2 diabetes over type 1. I just want to take a little step back and just remind everyone about frailty, just because I think it's something that again, to increase the awareness, and it's an area of interest of mine that I've done a lot of work in generally. And essentially what frailty is how well your body can cope with a lot of kind of, I guess, disease and illness related trauma it can get, or kind of like pressure it takes. So, even a cold, or if you have diabetes, or if you have heart disease, what body can withstand from that. And it's not related to age as such, but it's kind of linked, because as you get older, you're more likely to get other medical conditions, and it's your body's ability to withstand a lot of all those illnesses, and it's linked to that. The different ways we assess frailty. The reason I bring this up is I don't know if you can see it, but on this side, on the right hand side of the screen, the clinical frailty scale. This is kind of what I used in some of the work that I did, and essentially it tells you how, I guess, how functional someone is, how mobile, how robust someone is, especially the dementia side at the bottom. If you look there, this is why I like this, because it says in frailty in people with dementia, these are scales used mild, moderate, severe, based on the ability of their memory and ability to do self-care. And this comes in handy when I talk about the project that I did. In GP, so if you go to your GP, they have these scores that are based on what's put into the database in the system, and based on what medical conditions you have, your age, and a few other things, the system calculates a score and puts you in these kind of numbers, these scores on the left-hand side, and depending on where you sit, you may be classified as different levels of frail. And it's just something that's becoming more and more commonplace in a number of different, not just in diabetes, but in a number of other conditions and generally as well. So it's just something to be aware of. Diabetes is linked with frailty and aging, and so type 2 diabetes, so type 1 diabetes as well, but we have a lot more data in those with type 2 diabetes, because again, an older age group, most people develop type 2 diabetes, not all obviously, slightly older age, and so we get a number of people, but again, people with type 1 diabetes, again, we're getting a lot more of that, but it's just highlighting that there's a link between diabetes and frailty, and an increased risk of frailty with diabetes. As a result of that, we created some guidelines which are used. Don't worry too much. Just want to show that whilst it's all research, there are other things you can do with data, and thought. And actually, we created guidelines to look at how to manage people with type 2 diabetes in this setting and frailty levels. And again, it's just a whistle-stop tour of it. Just wanted to highlight that there are things around frailty going on, but really the focus of this talk was more around dementia. And so we'll kind of move on to that. just showcasing that across all continents, inhabited continents in the world, the number of people with diabetes is increasing, and this is what's important with this is actually, if you look at this group in the middle, 1 in 5 people with diabetes is above 65 years old. So again, whilst age is but a number, again, we're looking at links with other conditions and other things that can affect someone's ability to withstand a lot of illnesses, and that's where we get linked to frailty. But yeah, 1 in 5 people. So yeah, in some places even higher than that because of life expectancy. And this is what leads us to think, well, we should be looking at people with diabetes also as well. What other conditions? Managing someone who's 90 and has diabetes is different to managing someone who's 19 and diabetes in some extent, some ways. You've got to account for a different thing. So it's highlighting that actually we need to look at, one size does not fit all, as we know this with diabetes, whatever type of diabetes, we know that one size does not fit all. And so it's really highlighting that from I guess an older person perspective, and what happens as we age. And Diabetes UK do have a kind of a thing about healthy aging, and it's something that is being looked at more and more these days. It says people living with dementia and problems with memory and inability to function from the mental ability side, and again it's increasing really in a lot of the countries. And what that means really is that people with diabetes and are more likely to, I guess, have the association or live with some degree of memory dysfunction at time. Not everyone, some people. We know there's a link between diabetes and memory problems. That's still being looked at and kind of understanding a bit more about it, but we know that people will have both conditions because, again, as we said, people are living longer, and we know that dementia increases with age for a number of other factors, but age is one thing. And diabetes itself is a potential risk factor for memory problems as well. We'll skip some of this, don't worry. There's a number of different reasons why. I won't worry too much with that. Hypoglycemia and severe hypoglycemia can sometimes increase your risk of problems with memory, and that's been shown in people with type 1 diabetes as well as type 2. This is just showcasing that. I won't again dwell too much on that. And we know that risks of diabetes in people with memory problems can affect their blood sugar, blood glucose, affect how they present with low blood sugars, again hypos. If you have memory problems or you can't really communicate whether you're having a hypoglycemic episode or not, how do people know? And if you have memory problems or you don't, I guess, aren't aware of what's happening, how do you identify that you are having a hypo? And that's some of the things that, as people with memory problems and dementia, that's the kind of issues that we do have, managing them from a clinician perspective. And of course, the medications we use, we want to be extra careful. We don't want to increase the risk of further hypos and further worsening the memory problems. And of course, again, be identifying people with dementia and diabetes, knowing that they may not always turn up for to our clinics because they may not be aware, or they may be unwell for any reason, and they may not take the medication appropriately, or they may not follow some of the recommendations because they may not be able to. And it's about understanding the situation of everyone, and certainly people with memory problems, you should be extra careful with, and kind of highlighting that. That's what part of my role has always been, to try and highlight perhaps potential vulnerable groups. And there is some guys, but we'll move this. But I guess the main thing that, so this was all the kind of stuff that I looked at before and said, well, there's a lot we don't know about people with memory problems and diabetes, and there was not really much available at the time I was looking at it. There was not much available in identifying what was happening. Like, I didn't know what's happening in England with people with diabetes and dementia. There wasn't much data. I don't know what's happening even in my local area. In Birmingham, what was happening with a number of people with diabetes and people with dementia, what was happening in the hospital I was in at the time. And so this was really, so this kind of brought out kind of like not quite a frustration, but a want to understand and learn more about what was happening. So this is what we looked at, what was happening in our hospital at the time. And so this is called the Diadem Project. So diabetes, dementia, we merged it to make it Diadem. And we looked at people who came into the hospital. So everyone coming into the hospital at between a certain period of time, 2015 to 16, who had diabetes and dementia, we looked at them, be they coming in for a chest infection, or coming in for a fracture, or coming in for just to be seen just for another reason completely, like seen under surgeons or seen under the other teams that we have in our hospital. So as long as you had both diagnoses and were admitted to hospital, we reviewed the people coming in. And what we find in that 1 year, we had about 552 different people coming in who came to the trust with both conditions. So again, 552, which is over 1 a day, and it's almost 2 a day, not quite, but just under. And this accounted for over 1,000 visits. So people would come in recurrently, as you'd expect with the conditions. So they came in a number of times a year. Yeah. And look at the reasons. So we looked and see, well, so people with diabetes and dementia, what are they coming in with? And this is why it's important sometimes to look at real world, because then we see, well, what are they coming in with? And does that mean that we have to look at these certain groups or think, how do we help support people with diabetes and dementia if they're coming in with all these conditions? Is there anything we can do to reduce those conditions or to help support them so that they, when they are in, we can address things? So this is where real world evidence sometimes helps. It gives us a more practical, person-centered understanding of what's happening. And so kind of neurology means confusion. A lot of the time, as you expect, people with baseline confusion can get more confused for any reason. Any chest pains or heart problems, respiratory breathing, shortness of breath, chest infections, including that. So majority coming with chest infections or chest problems, and the second number with urinary tract infections or problems passing urine. Again, as you get older, the commonest causes of infections, really. So this is what we saw. Falls again. So trauma means they came in with falls. So we got an idea roughly. So people coming in with diabetes dementia usually had some infection, chest or urine, falls or confusion, and that was the commonest thing. So this gives you an idea sometimes when you think, actually, well, okay, we get a picture of the person and what might be the reason for them coming in. We looked at kind of the age group, so very small number were under 65 years old. These were arbitrary cutoffs. We looked and classified them based on standard age groupings. 66 to 75, a slightly higher portion. Majority were over 75, essentially. 76 to 85, a large portion, and a group over 86. So again, we're dealing with an older population again coming in, as you would probably expect, given the comorbidities. But again, it highlights that this is a different group of people that we need to make sure we help support. We looked at HbA1c ranges, so blood sugar ranges. Is very crude, but again, it was just basically what data we had, and we said, well, we can look at the blood glucose readings when they're in hospital, but actually just look and see what the last HbA1cs were, just to give an idea of what's happening. And as you can see, the blue is basically people who had an HbA1c less than 53, which in the setting of, I guess, as you're more frail and cognitive impairment and more unwell, the risk of hypoglycemia can be quite high, and the complications of hypoglycemia can be high. So we're extra careful, and we don't want to treat people too aggressively, but equally we want to balance that with the risks of complications. It's kind of understanding that a bit more, and we're getting better at it, but we're still a lot to learn. But it means that majority of the people had an HbA1c that was less than 53, which is good, but equally could mean that they could potentially be at risk of overtreatment if they're put on medications that can increase risk of hypoglycemia. Same thing in people who are in the target range of 53 to 60, we said. And people who are at an HbA1c over 70, technically we said, well, ideally we like it less than 70, so perhaps they might be undertreated. And again, there's a bit more subtle nuances to this, but this was kind of what we looked at. So we looked at about 350 people, and we looked at what kind of medications they were on as well. People not on sulfonylurea insulin, so a large proportion were not on the key medications that would cause hypoglycemia, so sulfonylureas or gliclazide or insulins. But a large number of people were on some form of insulin and other therapy or SUs, as you can see. So we looked at just over 42% were on medications that could have caused hypoglycemia. Again, crude data, because again, we don't know if they were on other treatments or they needed to be on those treatments, but it was looking at seeing generally as a trend, what do we see in this group? And this is some of the things, I think this is quite important. Sometimes that we looked at this because we got some ideas. So this is just a small snapshot of things. So people coming in with certain, for example, if we say this person who's 89 with HbA1c of 40, so again, if we want to aim for 42, which is diagnostic of some impaired glucose control, or 48, which is kind of the diabetes target. Someone with HbA1c of 40 who's 89 with dementia and diabetes, who's on tablets, 2 tablets here, but also gliclazide 80 milligrams. And we know sulfonylurea gliclazide can cause hypoglycemia, especially in people who don't perhaps need it. So again, this was highlighting that we perhaps could have, this person did not need to be on this medication. Similarly, someone who is who had an HbA1c of 47, who's on gliclazide, so again, it's a medicine called hypoglycemia, metformin, and another tablet, naltrexone. So again, 3 different medications for someone who's blood HbA1c, you would say was reasonable. It didn't need to be that. So again, it was about balancing over treatment as well, and that's kind of what we looked at. and then someone who's at 84, for example, HbA1c of 43, again, very, very stringent, sorry, but was on another form of something like glycoside or sulfonylurea, which can increase hypoglycemia, and also large amounts of insulin, which kind of worry. And this was something that was addressed and looked into. So again, it was just highlighting that at that point, the reason why it was so important was because we needed to identify this as a group that potentially are vulnerable to hypoglycemia, and they may be on treatments that are not needed, not required. And do we need to create some guidelines or some support and management so that we can avoid this and proactively go and manage such people so that they don't get hypoglycemia and come and admitted to hospital or have falls. And you can imagine someone who's 90 having a fall and damaging their hips or hitting their head compared to someone who's 19 having a fall and from hypo and perhaps having enough fat, muscle, bone strength to avoid any problems. I think this is to highlight that, and this is what led to practical changes and created kind of almost immediate changes locally which we implemented to kind of avoid such admission and such over treatment. And it's where research can really do things. So this is what we created, and it was called Diadem. I always like a good not mnemonic. What's the word I'm looking for? Mine's gone blank completely. Oh dear. Anyway, but yeah, we used Diadem to serve individual components. So D was so what we decided is that anyone coming in with both conditions, diabetes, dementia, we would assess them proactively and say, well, what do we need to do? How do we manage this person with diabetes and dementia so that we can support them as best as we can? And this is what we said, the Diadem approach. So D was for determining the degree of the dementia and how they can manage themselves. I was to involve the carers, the patient themselves, the person themselves, obviously, the carers and family in discussions and decision making. A was to assess and set goals for their blood sugars, looking at how stringent do we want to kind of aim and target their blood sugars or their HbA1c, and do we want, but also to provide support and guidance to anyone else who wasn't a specialist, and including the person as well, saying this is as a diabetes specialist, this is what we would suggest, and perhaps form a little kind of care plan. And again, D determine the risk of hypoglycemia, very important, and then also evaluate any risk of complications of diabetes, so the eyes and feet especially, because we know foot checks are perhaps not as well done in a lot of groups, and so we want to make sure that was done. And then we wanted to monitor them as well for any changes in the status and readmissions hospital and any changes in their blood sugars. So this is what the Diadem project was, and this is what we kind of intervened to look at. And what we did in that snapshot, again, what we did immediately in the first month of that is, that's not showing up, unfortunately. I apologize. That's a shame. The slide essentially shows that it's not here, but we intervened with a lot of subsequently people coming in, and we managed to reduce the number of people on insulin. Now, remember that a lot of these people will have type 2 diabetes rather than type 1. So in a lot of these people, we managed to reduce the number of people on insulin, but also reduce the number of people who are on agents that would cause hypoglycemia, so that'd be insulin or sulfonylurea, glycoside, things like that, and able to increase the number of people who didn't require their medications as much, and reduce the number of medications as well. What we found actually was that a very small number had type 1 diabetes at the time when we did the trial. I think as we move forward and as people are living longer, we will certainly, if we did this again in this data collection, we would just find a lot more people with type 1 diabetes. And again, still same rules apply. We obviously don't want to stop insulin, but we can certainly consider, do we need to reduce the amount of insulin needed or look at strategies to help prevent hypoglycemia. I think that's something that's these kind of small, single center local evidence gathering helps, because it helps target what we would do with people and helps make small changes which can expand to get bigger and bigger changes. And as a result of this project, actually, I was involved in guideline change with on dementia, looking at inpatients with some of these larger national organizations, a couple of different guideline changes so that we could direct and help support the whole of the UK clinicians with regards to this area. So it shows how even small grassroots projects can build and develop into bigger things and have impact nationally and actually internationally. I've been invited to actually speak. I'm actually in Romania actually in a few months to speak about this area, to highlight, and I've spoken in India about it. I've spoken in a few places just to kind of highlight the awareness. I think that's an important thing, that these things can lead to more kind of significant changes. And I think the main thing with this is that we need more data. We need more evidence. What you find with research is that it always asks more questions than answers in a way, and you find up saying we'll need more understanding of, well, what's the optimal management of someone with diabetes and dementia? What's the impact of the medications we use? All medications the same, or do we think about different ones that we need? How do we monitor risks, and what do we look at? Even current trials, current research going on. How can we incorporate dementia and people with dementia in those trials, because it's really hard sometimes to incorporate people with memory problems in trials unless they're specifically in memory. I think that's something that is coming, and actually we're getting more trials in this area. And I'll leave that with the conclusions. Really, diabetes dementia is increasing encounter clinical scenario with longer life expectancy and multimorbidity. We need to be aware. We need to make sure clinicians are aware, but also people are aware, and family members and carers are aware, so that we can. And really we're looking at trying to avoid over treatment and managing people with diabetes in the best way. I will leave that there, really. I think that's the main thing. What I do want to add really with this, I know we've kind of gone through it quite quickly, but it's kind of a snapshot of taste, the flavor of things. This is something from Diabetes UK and University of Leicester. This might come again with other speakers, but I've been asked to share this with people. If you're interested in looking at technology and accessing technology and want to be involved in research and study, the University of Leicester and Diabetes UK are looking at this Egality study, which is, if you scan the QR code, or if you want to look at that later, we can send the links, where they're asking for people to help support, to understand what the barriers to technology uptake, and what people would want to, I guess, what are the barriers for them taking up technology. And it's something that you can get involved in research wise, and it's something independent of myself. I'm not getting involved at all, but I'm asked to help support the project themselves, and just say, well, here you go, advertise it for people. And I'd like to leave that there, Tom, if that's all right. And if there's any questions, I think there's one here I'm happy to take on. But yeah, thank you for your time.
Thank you so much, Amar. That was fantastic. Just a quick question. There are a few questions in the chat, so maybe you can hang around and answer some of them. But one of the questions before we hand over to the next speaker is this one. Let's get this one up. Are there any practical strategies people with diabetes can do to enhance memory function so they can reduce frailty and dementia?
Yeah, so there's a lot of interest in this. Again, so in terms of specifics in people with diabetes, the only thing proven to reduce frailty or support frailty is actually exercise. So exercising work, and it's not like kind of going to the gym crazy exercise, which is good if you want to do that, but it's actually kind of simple exercise, weight bearing, lifting heavy, lifting loads, and strengthening exercises, and any form of exercise, even just walking is fine. But keeping active and getting your strength and muscle strength helps with frailty. Reducing frailty has been shown to. So that's probably the most important thing, regardless of if you have diabetes or not. That has been shown to improve it. And the older you get, the more important it becomes to continue that exercise. So that's the key thing. Exercise now. We all need to exercise more. I'm part of that. I don't exercise enough, unfortunately, but I want to. But I think, that's the main thing. Also, in terms of memory, so protecting the memory, exercise does help. Risk factor reduction is what we say. So basically, managing the risk factors for memory impairment, which is high blood sugars, which is high cholesterol, which is high blood pressure, as well as stimulating the memory. So we know that things that stimulate stimulating your brain power help as well. So I think in the news a few years ago, maybe even longer, was Sudoku was good for memory. Basically, anything that stimulates brain power, stimulates the brain activity and tasks, doing certain tasks. That's what helps with your cognitive function. So how your brain kind of analyzes and does things. So anything like that is simple things to do which help keep, you, as I say, you always say, brain is a muscle. You need to use it. But in terms of frailty, it's exercises are the best thing for anything.
Brilliant. I hope that answers your question there, Belinda. There are a few more questions in the chat. Hopefully you can hang around and answer a few of them. But thank you, Amar, for kicking off our research event. Thank you so much.
Enjoy, everyone.
Cheers. Thank you. All right. Let's see who we have next. We have Dr. Tom Crabtree, and he is a endo registrar and ABC research fellow at the University Hospitals of Derby. He has interest in diabetes technology and sustainability recycling. And Tom was heavily involved in the NHS England closed-loop insulin delivery pilot, and he'll be here now to talk a little bit about that. So welcome along, Tom.
Hello. I'm just trying to remind myself how I share my slides.
So I can bring that up. Here we go. Here we go.
Good stuff. Cool. So yeah,
Brilliant.
thank you for the intro. I was listening to Amar's talk and I was like, oh, is he going to steal some of my very, very much similar minded to Amar? You know, there's loads of people who are doing really fancy stuff in labs. But actually I think real world research is really relatable and understandable and can help us sort of see things as it moves along. And what I'm going to be talking about really is the NHS closed loop pilot, and it's a little bit different to maybe what Amar was talking about in terms of real world evidence, which was sort of seeing the lay of the land. But actually, what we do know is lots of randomized control trials for new medical devices or drugs are done in very controlled environments. And for anyone or watching that has ever been part of a randomized control trial will understand that they get phone calls off. You get phone calls off of nurses every week. You're super well supported in a way that just cannot be delivered by the NHS. And so I say that's a little bit like learning about those new devices, like learning about a lion in a zoo. So you'll probably be able to find out a lot about lions by studying them in that environment. But if you really want to see how a lion behaves and what it does and how it lives its life, you need to go on safari, and that's where real world evidence plays in. And sort of adds value really and allows us to see how that translates into what we're doing in the real world. So I would continue to say that randomized control trial evidence is the cornerstone of clinical evidence, but we do need real world evidence too, because we know that we're more poorly resourced. We have people who perhaps would be excluded from trials because of medical conditions, and we know that people in the real world are much less closely monitored. And so the idea came about, sort of led by Parth Carr, who did this scheme via NHS England and gave us access to additional funding to put people who were already using an insulin pump, a Freestyle Libre sensor, and a HbA1c of above 69 at some of the larger pump centres, not everywhere in the country, onto closed loop just to see essentially how they would get on. And then we captured those outcomes as the ABCD-DTN UK team using an online tool. And all we would do is take anonymized data from the people who were in the pilot just to see how they were going on. We didn't do any extra tests. We didn't do any extra blood tests, anything fancy. We would just look at what happened to them during that time period. And I think this is the main finding that we've reported. And I think when it comes to closed loop, I think anyone who uses it would say that they get reductions in glucose levels, and actually a reduction of 18.1 millimoles per mole is nothing to be sniffed at all. In fact, it's probably the largest reduction that's reported by any single intervention in type 1 diabetes, which is really impressive. And then we know that translates into increases in time in range as well. So you can see here the before and after sort of your Libre bar stack kind of display of time in range, but we got that increase of 27.8% time in range, mostly that being reducing that time spent above 14, so with the very highest glucose levels, and some smaller impacts on time below range as well, which were significant, but 1.8 to 1.3 may not feel like a lot. And I think the main thing when we speak to people in clinic is we appreciate that hybrid closed loop therapy has a significant impact on quality of life. And if any of you using it, hopefully that's something that you started to benefit from, or something that you really appreciate now that you're using the system. Diabetes distress is one of the common scoring systems that we use to assess people's distress from their diabetes. And we saw reductions in those scores of 1.1. We also can diagnose diabetes distress using the same scale if anyone has a score of 3 or more. And we saw that about 7 out of 10 people at baseline had diabetes distress, which reduced all the way down to 2 out of 10 after 6 months of follow-up. We also saw some improvement in hypoglycemia awareness as well, which is good to see, although that might be the benefit of the alarms, perhaps more than the benefit of a closed loop. We can also use this sort of real-world data to look at sort of hospital events and the sort of things that happened. And we didn't see any change in acute admissions rates, so there wasn't an increase or a decrease. And we did see a little bit of increase in DKA in those first few months where we started the pilot. And I think that's because we all underestimated the amount of education that people still needed to go on to closed loop. So things around like reacting to high blood glucose levels appropriately, doing set changes to prevent DKA from those sort of cannula failure situations that people come into, all very important. And actually, once we learned that that was needed for people who were putting on the systems, we found that petered out. And actually, by 6 months, there was no difference in the amount of DKs we saw. We also saw no change in paramedic call-out rates, which were fairly low to begin with. And we were also able to capture some of the problems that people experience with closed loops, which can be really informative. Mostly people were talking about skin site reactions. There were some concerns about sensor failure or inaccuracies, which I think anyone who's using CGM of any description has probably experienced at least one sensor. That's been a bit iffy, for lack of a better way of putting it. We also had 50 individuals out of the 500 that were part of the pilot who discontinued the systems, which just goes to show that perhaps technology isn't for everybody. But lots of that was because they were struggling to trust the system. The severity of the skin site reactions did stop some individuals from using it. We probably need more work around how to prevent those from happening and how best to support people in that situation. Some people had some early problems adjusting to closed loop, which again is probably more around the anxiety, but we classified those as being something slightly different. And there was a small handful of people who, for whatever reason, we were concerned about as the clinical teams looking after them, either because they weren't sort of appropriately responding to high blood glucose levels, they were putting themselves in potentially unsafe situations, and we were trying to mitigate that. But ultimately, we saw more people were reaching recognised glucose targets. So if you think about HbA1c of less than 58, which is actually the new cut-off in the NICE guidelines for access to closed loop, then we saw people obviously weren't meeting that at baseline because you had to have one above 69. But of all those people who were above 69 millimoles per mole at the start of the pilot at 6 months, about 15% of them had a HbA1c of less than 58. When we look at time in range, we had a small number of individuals who did meet that target, so their HbA1c was perhaps on the way down as they started the pilot and hadn't quite caught up with time in range yet. But we had 45% of those with a HbA1c with a time in range, of greater than 70%. And then when we look at that composite outcome that we sort of aim for, ideally, of time in range more than 70, time below range of less than 4, then we're getting about 25 to 30% of individuals meeting that target at 6 months, which is really good to see. And people love closed loop systems. 97% would recommend the systems to others, and 95% noted improvement in quality of life. And this is all really important, and all of this data that I've shared has been fed into NICE and into the closed loop appraisal, which is now obviously live or thereabouts, and is about to be rolled out across the country, which goes to show how seriously real world data is taken and how powerful it can be, and how it can really stand to inform policy on a national level. So it's thanks to this scheme, in part, lots of the work from companies with their trials as well, and obviously the funding for this scheme coming from PARFA and NHS England, and for them taking it so seriously at NICE, that we do now have more broad access to closed loop in the UK, which is great to see. I'm going to leave it there. I don't know if there are any questions or anything.
Thank you so much, Tom. I just think that's really interesting to see. I know we briefly spoke about it on Diabetes Chat on our normal Monday nights, but seeing the sort of visuals and everything, and I've just wrote some things down, like the plus 27.8 increase in time in range, and the biggest one I find really interesting is that one there. 95% of people saying it's improving their quality of life, and you know what I mean. It's not a pancreas, is it? It's the technology, but the person has to still invest a lot of time in it to work the technology. It's not a cure. It helps, and it helps with elements of people managing diabetes, whether it's sleep or go like traveling and loads of things. And you can just see with them figures there how it is really helping people. And now, like you say, with the TA and things like that, it's really going to help shape diabetes care, isn't it?
Yeah, and I think it's the power of real world data, but it also means this is what's continuing in real life. We've got 12-month data that we're about to present at ATTD in a few weeks as well, with broadly similar findings. We know that these outcomes continue in the long term. I think quality of life is important, but I think it's also to accept the limitations of technology. It's not a panacea. Closed loop isn't going to solve everyone's problems. There's annoyances with it. If anyone's using it, you might experience problems with alarms, just days where you want to throw it all out the window because it's just not working for whatever reason. So, technology comes with its problems, and I think we need to recognise both sides of it, the potential improvements, but obviously the new issues that it might introduce, and also then think about ways that we address those to minimise that burden.
Definitely. Thank you so much, Tom, for coming in tonight and sharing that. If you have any question, guys, please put it in the chat box, and Tom might stick around for the next 5 minutes or so and answer any of your questions. Thank you so much, Tom. So let's have a look at what is coming up next. What a fantastic start to tonight's Diabetes Chat research event. I hope that you guys have found it really useful and taken things from tonight. I can see the chat is really buzzing with people talking and asking questions to our speakers tonight, so that's really good. So our next speaker is Dr. Lauren Quinn, and Lauren tonight will be talking about the study ELSA, and you can check it out, elsadiabetes.nhs.uk, and it is a type 1 diabetes screening program which is in the UK, and it's for children aged 3 to 13. So welcome to Lauren. Hello, Lauren.
Hi, good evening, Tom. Thank you so much for the opportunity to come and speak to you this evening.
No worries at all. Thank you for coming. I will put your slides up to the screen and then over to you to share. Thank you.
Great, thank you. Thank you for the opportunity to speak. My name's Lauren Quinn. I'm a clinical research fellow currently at the University of Birmingham, and it's a great opportunity to tell you a little bit more about the ELSA study. I hope many of you have already heard of the ELSA study. Some of you may have had children even participate in the ELSA study, and it would be great to hear from you. But for those of you where ELSA is new, I'm going to tell you all about what we're doing, why we're doing it, and then what our next steps are with the ELSA study. So ELSA is screening children for type 1 diabetes in the UK. So this is the largest national programme for general population screening for type 1. The ELSA study is co-funded by Diabetes UK and JDRF, so the two major diabetes charities in the UK. So I hope it's really nice to see where all the fundraising efforts, it goes into funding research just like this. And the ELSA study is led by Parth Narendran. He's a close colleague and supervisor at the University of Birmingham. The stages of type 1 diabetes, and many of you might not be familiar with this, but when we traditionally diagnose type 1 diabetes, as you'll all know, there's this rapid symptomatic onset. So thirst, passing excessive urine, it's those 4 T's of type 1 diabetes. But once you've got to that stage, you've already lost a significant and the majority of your beta cells. So the insulin isn't there, so you go into sort of that emergency presentation, and 1 in 4 children still present as an emergency to hospital in diabetic ketoacidosis. So that's actually quite a late stage of the biological process. And what we know from monitoring children over the last 20 to 30 years is that antibodies are actually the first marker of type 1 diabetes. So these antibodies they target the insulin producing cells or the beta cells in the pancreas. So they're specific for type 1 diabetes, and they kind of linger in the background. And they're signaling to the immune system to ultimately do the damage in due course. But because the antibodies are there for 10 to 15 years before someone even develops symptoms or needs insulin, that therefore gives us an opportunity to screen for these antibodies. So a perfectly healthy child, we can do a blood test, we can look for the antibodies to see if they're there. And this is important because what we know is if a child has 2 of these antibodies or more, 2 different types, they have an almost lifetime certainty of developing type 1. So in medicine, nothing is certain, and none of us can predict the future or when type 1 diabetes will happen. But we know that the majority will progress to needing insulin within the next 15 years. So because we kind of have this biological reasoning and background, there is therefore an argument for screening. And that's where ELSA comes in. It's modelling a screening programme in the UK to see, does it work and how can we roll it it out. So those are the stages of type 1 diabetes. And in what we call the general population, so if you just took, say, the UK population, you would expect 3 in 1,000 children to have these multiple antibody markers. So these 3 in 1,000 children have an almost lifetime certainty of type 1 diabetes. Now, I must say, if you have a family history of type 1, so a parent or sibling with type 1, as I'm sure you'll know, there is an increased risk of type 1 diabetes. So it's more like 2 to 5 children in 100 would have these multiple antibodies. So yes, there are these arguments for screening family members more so than general population. But I think both groups are important because 3 in 1,000, it's rare, but it's still an important number of children. And there are screening trials going on all across the UK. So Italy is actually the first country to mandate screening. So, I mean, Italy do screen for a lot of conditions, a lot more than we do in the UK routinely. But they've stipulated that all children in Italy should be screened for type 1 diabetes. In the UK, we're a bit further behind that. We're at the research stage to see how this works and whether it should be considered for a population screening program. And I think, honestly, we're a long way away from that, but the research is really important to help us answer those questions. So what are the benefits of finding a child who's at risk of type 1 diabetes? So I think the first thing is, if you know your child is at risk, we can educate you. We can let that family know about type 1 diabetes. I know I'm talking to a room of experts today, but if you imagine a family who don't know anything about type 1, I guess you've got that opportunity to introduce them to the type 1 community. You know, this is what a future with type 1 might look like or might hold for your child. So you can get familiar with technology, with all the best treatments. You know, you can become well informed. So that's one benefit. The second benefit is we want to smoothen the transition to diagnosis. So we want to prevent diabetic ketoacidosis in children. And through screening and monitoring, we can do just that. We can see when type 1 is starting. We can get that child on insulin in hopefully a much more controlled fashion. We might even be able to avoid a hospital admission, which, with a diagnosis of type 1, as you know, traumatic and life-changing as it is for a family, or it can be, we just want to smoothen that out. And then I think the other really exciting part of this field is access to promising new treatments. So the idea is, if you screening and finding someone at risk, could we put them into a research study testing a new treatment that's trying to delay the start of type 1 diabetes? We're not at a cure, we're not at prevention, and we're a long way away from that, as you know. But even if you could push the diagnosis back by a few months, a few years, that's a few years without insulin and without glucose monitoring, you know, every day. So there's that benefit of preventative treatment. So these are the benefits of screening for type 1 diabetes. So a very quick overview of ELSA. So ELSA is actively recruiting in the UK children aged 3 to 13 years without type 1 diabetes. It doesn't matter whether you have a family history of type 1 or not. Any child 3 to 13 can take part. We're recruiting 20,000 children, so it's an ambitious study, and we're looking at feasibility and acceptability in the UK. So seeing how this might work, how we can recruit, and what do families think of it? If they do have a child identified at risk, what's the impact of that on the family and the young person? Because with research, there can be benefits and there can be harms, and we need to have a good appreciation of both of those and how they balance out. So I'll skip through this, but basically with the screening test, I should have a slide for you, but I can't see here. The screening test, yeah, here it is. Sorry, this is the dry blood spot. So it's a finger prick. It's a slightly bigger lancet than what you're used to with your capillary blood glucose testing, because we need a bit more blood, and the blood goes onto the blood spot card, and then that can be sent back to us in the post or via the community settings. So that's the screening test. And basically, if the child screens positive, we then bring them back for a blood test to confirm the antibodies. And then if that confirms multiple antibodies, we then bring the child back for a glucose challenge test. You may know this from sort of gestational diabetes is frequently where we use OGTTs, but it's also the most specific test we can use in early stage type 1 diabetes. So that's the test we do. And then we bring the family back for an education session. So one-to-one with the ELSA team. These are your child's results. This is what it means. And now let's think about next steps. So monitoring studies to follow up that child, but also this is the prevention trial arena. This is what's coming down the pipeline, and we want you to be aware of these trials as they come through in case that would be suitable or acceptable for you. So that's the kind of overview of ELSA. And then I think this is probably the most important slide, is what support is in place for families, because, finding out a child is at risk. It's almost like your child is diagnosed with type 1 diabetes at that point. So we do the education session for the families. We do have a clinical psychologist we work with. So if there's, if a family are going through that anxiety and distress with diagnosis, we can do that referral and talking therapies for both the young person and the family. There's the follow-up, there's the prevention space, and then we also let the GP know. So if the GP knows your child is at high risk, then they should have a lower threshold. If you come in with concerns about osmotic symptoms, okay, do we need to check for type 1 diabetes a little bit earlier in the process? So trying to improve the diagnosis for the young person. So that's the kind of support package that's in place. So in terms of the ELSA study, we launched on World Diabetes Day 2022. So we've been going for about a year and a half almost now, and we're open until August and hope to extend. But we had an amazing reception from the diabetes community, and we're so grateful to the charities, but also to yourself for raising awareness of the study. And you can see just the most important thing on this complicated graph is we've recruited almost 13,500 children have already been signed up to this study. We've had about 8,000 blood spot cards returned. So obviously as an active trial, we're still waiting for some to come back to us. And we've also had about 2,000 children recruited through community settings. So that might be schools or general practices, for example. So bringing research to families who might not otherwise have heard about it, or they might not know about the diabetes community or social media. So it's really important to raise awareness of screening and these diabetes research opportunities for those families as well. So this is kind of our heat map. We have opened in Northern Ireland now, so that's the only nation that's missing from this map. But you can see the amazing activity from ELSA all across the UK. And these are all of our follow-up sites. So, in the rare chance that a child would need further testing, we try and limit that travel burden as much as possible for the family. And then these are just some photos from our community clinics. So these are in Birmingham, but working with families who are underserved for whatever reason. They normally can't, or they're not able to access research. There might be language barriers, there might be cultural barriers, although it might be refugee status, for example. We know all of these communities often miss out on these amazing opportunities. So to directly tackle that, we bring the research to the communities, and we've learned so much from this process and had such a great reception. So in terms of ELSA progress, this is my final slide. So we've come a long way. We started off in 2021, speaking to families, speaking to stakeholders, what would you want a screening program to look like? We then engineered it to bring all of that feedback into the ELSA study. And if you look at the website, it's all been designed with people with diabetes living with type 1. In 2022, we launched at the end of the year. 23, we had a great reception and great recruitment. And now, really exciting news in 2024 is we're rolling out the ELSA model to countries across Europe. So Poland, Czech Republic, where else do we work? At Portugal as well. All these countries are going to roll out an ELSA equivalent to their families. So that's fantastic news. And I also just wanted to give a shout out to the TEDRA study, which have a look at this link because they're screening adults for type 1 diabetes. I don't have time to go into the biology of that today, and there's not as much certainty as there is with screening children for antibodies. But if you're interested and you don't have type 1 diabetes, you are welcome to be part of that study. And all of this helps build our knowledge and understanding of type 1 diabetes, its biology and its causes. So please have a think about being part of that. A huge thank you to the much wider ELSA study team, but the most important people to thank are the 13,000 children and young people who've been part of this study, and the parents who've signed up their kids, the majority of whom have done the screening test on their children at home. And we know that's not the easiest task. So we're so grateful. And we look forward with the ELSA study. We're going to start publishing our results, maybe the end of this year, maybe next year, but as soon as we can, we'll get the results out to you. So thank you, Tom.
Thank you so much. That is so fascinating. And I think it's great that we are in 2024 and there's things like the ELSA study that give parents and children the option, the choice to participate in these studies and find out these possibilities of if they'll have diabetes. And like you're saying, it's looking at ways of maybe hoping to prevent hospitalization and things like that. Really interesting seeing the visuals tonight and seeing 3 in 1,000 people, which, you know, it is a small number, but it's still 3 people in the grand scheme. There's a few questions coming through. We'll do a couple. I did ask, is there a reason it's 3 to 13, and will the ages extend from both sides, so younger children and older children?
Great question. So the antibodies, they usually arise around the 2nd year of life. So unfortunately, we can't test for antibodies on like the blood spot card that's done on all babies. We have to wait a couple of years for the antibodies to arise. We chose 3 because we could piggyback it on the vaccination program in primary care. So that's why 3 was selected. And we went all the way up to 13 because we do know there's some changes around puberty with the biology of type 1 diabetes. So it was a pragmatic decision to go for 3 to 13, but there are possibilities to extend the age range, and that is something we're looking at as well, up to kind of young adulthood.
Brilliant, that's great. Let's have a look. Question on Instagram: is this study trying to get the same results as similar studies in other countries? I don't know if there are other ones. I'm not sure which ones, but question for that.
Yeah, great question. So ELSA is actually modelled on the FRIDA study, which is the German program, and they've screened like well over 100,000 children in the last 4 or 5 years. So yes, we're doing the same model, but our research questions are different. So we're looking at feasibility and acceptability in the UK. And that's really valuable because we're the NHS, we're a public health system. If we can determine how screening should work in a setting like ours, it makes it much more accessible for other countries, other health systems around the world. So people always listen to NHS-based research, and that's how we're modelled in the ELSA study. So that's feasibility, but also acceptability, you know, actually understanding the implications of screening. We know there might be harms. We know it might cause anxiety or distress for families to be given this information. It's difficult news. So we actually want to understand the extent of that and how can we support families who do have a child identified at risk.
Yeah, absolutely. 2 quick ones. Is it a one-off test, or would it be repeated of, say, a child was young when first tested?
Yeah, good question. So at the moment, ELSA is just a one-off screen. And then if a child was identified as the high-risk category, they'd be offered 2 yearly or 1 yearly follow-up testing, depending on their risk. But if a child, the younger a child is and don't have antibodies, there are arguments to retest the child around the kind of 8th or 10th birthday. That's not currently engineered into ELSA, and there's still a kind of research around the world trying to decide what are the best ages to screen children. But yeah, if you've got to like your 10th birthday and a child doesn't have the antibodies, it's reassuring that child is unlikely to get childhood type 1. We can't talk about adult onset type 1. That's a bit more challenging. But
will there be screening tests for adults? Is there screening tests for adults?
Yeah, so that's what the TEDRA study is. TEDRA is antibody screening for adults. So it's all home testing. You can literally go onto the website and order a kit here and now if you don't have type 1 diabetes already. So please spread the news about TEDRA, because they've already recruited thousands of people around the UK.
And we've got this message come through as well before we finish. I've been so scared to do this. I signed up last Monday, and this has confirmed I made the right decision.
Oh, thank you so much, Lisa. And yeah, if you've got any more questions, I'll put my email in the chat as well if you want to have a chat. But I do appreciate screening is not for everybody. And we've had some families just tell us, why on earth would I do this when there isn't a prevention or cure? So we do understand that side of the argument. And if you do have those concerns about screening, equally, we want to hear that, because it helps us understand the wider implications and how we can support families and what the right thing to do is. But absolutely, we're here to listen in the ELSA team, and we're here to kind of get the best out of a screening program for the future.
That's brilliant. But yeah, if you stick around in the chat, Lauren, there may be a few more questions come through, and if you can send the links to all the studies that you've mentioned, that would be great, and then we can share it on all our social media platforms. But thank you so much for coming tonight and sharing the ELSA study with us. Thank you so much.
Thank you, Tom.
Bye-bye. Okay, guys. Wow, what a fantastic night we're having here on Diabetes Chat research event, sharing lots of different research. We are slightly behind time, but it just shows the important discussions that we're having. And it does not stop there. We have more speakers coming up now from James Ridgeway. He is a person who lives with type 1 diabetes, and he has two roles, one at the Education Research Associate for Eden and also as a diabetes specialist nurse. Tonight, he'll be talking about a newly funded Eden education project that is being developed that aims to support people with living with type 1 on how to set up and run peer support. And this is really, really important, as we see online and in person, the importance of talking and finding communities and peer support. So welcome along, James, to Diabetes Chat. Hello, James. Oh, your microphone, my friend.
Is it working now?
Oh, working. Hello.
Hello. Well done as well, Tom. Just want to say first, well done on this great event that you're doing. It's brilliant.
Thank you. Yeah. This is our fourth one, and tonight we're doing all with cameras and slides, and I think it just brings that different dimension and aspect to the event that people can hear it but see it as well. And we're looking forward to hearing your chat, and happy Diversity, James, as well. It's your Diversity today. I must mention that as well.
Thank you very much. Yeah, no, and looking forward to chatting about our exciting project as well, which will have some element of potentially your involvement as well as an audience, which I will provide you with a link. So yes, so this presentation, which I'll go through for about 10 minutes or so, is titled, as you can see there, Peer Support Champions. And as I said, Tom said, my name is James. I work as an Eden educator. Well, the full title is Education Research Associate, and we're based at the Leicester Diabetes Centre. Eden stands for Effective Diabetes Education Now, and we deliver and develop diabetes education as well as other metabolic conditions such as obesity, chronic kidney disease, heart failure, cardiovascular disease, to healthcare professionals, but also social care. And we're touching upon an element around the person living with diabetes, particularly with this program, which we're in development of. My other role is as a diabetes specialist nurse based at the University Hospitals of Leicester NHS Trust. So I'm hoping that the slides work. There we go. So I'm going to first quickly talk about what it is, and then I'll talk a bit, kind of going back into the background about why this has come about, the importance of the project, and also the importance of peer support. So peer support champions in type 1 diabetes. So it's an online interactive education program around facilitation, leadership, and peer support. Participants involved will be those who are living with type 1 diabetes, using or interested in technology such as continuous glucose monitoring, insulin pumps, hybrid closed loop, and the program aims to help the participants how to set up, run and sustain a peer support intervention of whatever type that person wants to do in that particular area. The program is to be launched in July of this year. So in between now and then is our development time, and we've already started some development, but we want to hear from the people living with the condition to understand what they really want to be involved within the program itself. So you've got a, you can be fully part of it, involved. And as it says there at the bottom, this program is funded by a grant from Insulet, but the contents of the program for its delivery is independently developed by ourselves in Eden. So if I move on. So this, you might have heard about the 3 pillars of diabetes. So this is the background to the project, or the reason why. So Parthakar said that there were 3 pillars to self-managing diabetes. That is access to trained professionals, self-management, and peer support. Now, I think that the 3 pillars align with all types of diabetes, to be fair. And if we think about that first one, you may have heard me say this question before, or even heard this in from other people or other places. The question is, on average, how many hours per year does a person with diabetes spend with a healthcare professional? And the answer, according to Diabetes UK, is 3 years on average, which means that for the remaining 8,757 hours is based pretty much on self-management, plus the 3 hours they would be getting support, they still have to self-manage it as well. But there's a gap of around 8,757 hours. And that gap can be plugged a lot by peer support. However, it's one thing which Tom, I'm sure, will certainly agree with. It's one thing to say, let's set up a peer support group, and it's another to actually do it and making it thrive and sustain as well. And this is a great example of all the hard work that's gone into doing a peer support intervention. So for those that aren't sure, hopefully you've kind of got the gist of what peer support is through just this platform. But in essence, peer support is an effective self-management intervention which happens when people with similar long-term conditions or health experiences come together. And it's like finding one's tribe, and it can be life-changing, literally. And it occurs when people share common concerns and draw upon their own experiences to offer support and to help others. So it's a bit of giving and receiving of information, ultimately there to help one another. The benefits, well, I'm sure that many of you that have been involved in this diabetes chat have found many benefits alone, but the benefits of any peer support intervention kind of highlight some, if not all, of the following you can see on your screen. So enhances one's well-being, quality of life, creates friendships, companionships, helps them to problem solve because they can learn from others, helps them feel more resilient, self-efficacy, which means the belief to do something themselves, and obviously confidence. And I think the big one there in the bottom right is around feeling less alone. So in terms of the types of peer support, now there is not one right model to doing peer support. I think that the more the merrier, and the more variety the better. So there's telephone support as an option, there's online support, and we call these traditionally docs, which is known as diabetes online communities. So you can see some examples there around the globe. So GB-Doc here, diabetes chat, D-Doc, as well as the Derby type 1 Facebook group as well. There's one-to-one support, which can be through a coach who's trained in facilitation, leadership, and coaching around peer support. And then quite a common one is around group support, which can be encompassed around informal support, such as gardening, or more formal support, the one that I do, which is podding peer support, I'll just briefly mention. And then a lot is based around self-management programs. So for example, DAPHNE, which stands for Dose Adjustment for Normal Eating, which was a supportive education program for people with type 1 diabetes, and then Desmond, which is a self-management education program for type 2 diabetes. So any type of peer support has a benefit, but you can see that there's a wide range that a person can do, and that a person who wants to do a peer support group and lead it can go along with. They can do telephone or online or one-to-one, or create a group support network. Now, one statement that has been identified before, even the NHS has highlighted it, is that that peer support is there's not enough of it, and we need more of it. But luckily, times are changing. We're seeing much more things being highlighted and made aware of. That's really bringing peer support to the forefront, such as this presentation right now. So we've had the 6 principles of good peer support for people living with type 1 diabetes, and that's a really good guide as to what makes a good peer support group, a peer support intervention, a really good little piece of document there that you can do as an easy read. Obviously QIC, which is the Quality and Care Diabetes Awards. So last year was the first time they had a category in peer support, and it was won by this very platform here, Diabetes Chat. And Diabetes UK, they sort of revamped their search engine, which allows you to identify peer support groups in your own local area, which was in collaboration with, I think, NHS and JDRF. And that's really come to the forefront, particularly since COVID. I think we saw a lot of drop-offs of peer support groups since COVID hit. So next slide. So ourselves in Leicester Diabetes Centre, we see peer support as a really important part of our structure or organisation, which we see 3 key main areas: research, innovation and education. So peer support has mainly been kind of involved and embedded in a lot of the interventions that have been done. So My Desmond is the online self-management portal for people with type 2 diabetes, and that allows the chat function for other people to learn from one another and gain peer support in that way. M3 looks at young people with type 2 diabetes under the age of 40, where they have hubs around the community of Leicestershire and Leicester, and it allows people to come together and learn and discuss with one another. Healthy Goals is an intervention that supports people from South Asian backgrounds with type 2 diabetes, and a really good part of that, they'll learn with one another, have education sessions, but they'll also have kind of physical activity sessions, cooking sessions. They'll all be together. It's a really good intervention to be part of. I think they have 12 weeks with a cohort. And on the bottom right is one that I'm involved in and lead on, which is Podding Peer Support, which involves people who are interested or using Omnipod, whether that's Omnipod Dash or Omnipod 5. And that was due to a request from our diabetes service that I work for. Their lead was saying that there was more and more people using the technology, and there was a request for more peer support. So that's been going over a year now, actually, this month. So you can see the 3 people on the slide there, and one person says it's not just about being a person, it's about being the right person, and to be the right person we need education and support. And that's all about being that person that goes and takes on a peer support group or comes onto and being involved in a peer support group. That's already established. It's certainly one thing to just say, yes, I'll go and do it, but then it's another thing to do it. There's many skills that someone needs to learn and develop, and you can learn as you're going along, by sure, but sometimes it's easier to be prepared before doing it. And that's where we see our program that we're developing as a cornerstone for that. And a key part, as you can see, there's a lot of skills that a person needs to have or develop already before they actually go out and do peer support. But certainly for anyone that's doing peer support, I'm sure you've developed much along the way. So the key question is, how do we create, run, thrive and sustain peer support? And NHS there states in 2 years ago that there's a pressing need for more peer support groups. And I mentioned how COVID certainly made an impact, a negative impact on the amount of peer support groups that were around. Ourselves in Eden and the LDC see the value in peer support, leadership and education / facilitation. And this was actually highlighted as a need and as an opportunity for the community in the ASD conference in the DDoC symposium last year. And the link for that and the time frame exactly where the person was talking about it is at the bottom of your screen there. So a bit more of a dive. So I've kind of given you a background, so a bit more dive into what the program is, what we're designing. So it's presently in its development phase. What we will involve is a short education program for people that's wanting to participate. There'll be a welcome online discussion, which will be about 30 minutes long. Just gives you a bit of a welcome discussion, probably myself, that will be on there, as well as another member from Eden. There'll be a short online interactive education module. We in Eden certainly make them as interactive as possible, video, games, etc., to meet all learning styles, which is approximately 90 minutes long. And then you'll have an opportunity for a post-education online discussion forum, which is kind of like mentoring almost, way of chatting to other people that are going through the program, and also ourselves, and seeing how you want to go further beyond the education and how you may want to look at peer support groups that are established and being involved in them, or create your own peer support group in whatever type or types you may wish to do. There'll be an opportunity as well to involve the diabetes service or any relevant representatives that are part of it, such as Inselect, and certainly ourselves who've done part in peer support. We found a real big part of that that's made the success is actually involving and discussion with our hospital team, because they've been the key cornerstone to actually give out communication, sending emails to other people. When people have done the education, the mentoring, etc., there'll be a short refresher module. Again, the key thing is this will be free for people to register and take part in as well, because it's a funded program. They'll also have a supportive toolkit as well, containing guides and resources, and then you'll have virtual medals and certificates each along the stage, such as if you've done the education, you'll get a certificate or a virtual medal that way. If you've registered a group or created a group, you'll get a virtual medal that way. And to help its development, as I mentioned at the start, we'll be gathering feedback, particularly from patient and public involvement groups, so PPI as well. But not only that, we're also trying to ask questions such as right now. So we normally have an interactive Slido. This is a word cloud one, but we recognize it's not working on this platform. So what I've done is I have just put a link to that Slido. Now, it won't show up on this screen, but what I will do is, if you want to put a comment in, so the question is, what would you like to learn if you took part in this program? So if you meet the criteria for it, so if you have type 1 diabetes, or even if you're someone who's supporting someone with type 1 diabetes, what would you want to be involved in this program? What would you like to learn to get the best out of it and take forward from it? There was a question there. So will the project be available for type 2 diabetes? Not at this moment in time, Claire. The plan will be that we hope to see how this program goes, and then our plan will be to take it forward to other types of diabetes and other long-term health conditions. So this will be almost like a foundation to see if the platform works, and then we will then hopefully go on to other areas. Want to kind of start on a small scale initially and then roll out further from there. So if you want to put in your comments to that question, that would be great. And yeah, on the Slido itself, or you can put them on the comments here on the chat. That would be great. And then if you are interested, or you know that someone that lives with type 1 diabetes is interested in participating in the program, again, it's going to be launched in around July time, but you can express your interest by clicking on the QR code, scanning it on your phone, and it'll take you to a registration form, or you can send an email to ourselves in Eden, that's eden@uhl-tr.nhs.uk, and it will allow you to express your interest in the program. And if you want to chat more about it, you can always contact us, and more than happy to have a chat about it. And then one last thing I want to do is just, I used this at one of the conferences I was at when I spoke about peer support, and how we as healthcare professionals can do so much, as I am one obviously, but I also live with type 1, but there's so much that peer support can do that we as healthcare professionals cannot do. And one of them is that connection and learning from one another. And understanding what it's like living with the condition, and that's why your community may really be your superpower. And this program, we hope to make a good success and hopefully make a difference to some people's lives, whether they're receiving peer support or taking it up from doing this program. So I think I am at the end. Yes, thank you for listening, and if you have any questions, then I am happy to answer them. And that's it.
Absolutely fantastic, James. You know what I mean? You know how much I see the value of peer support and starting diabetes chat, but seeing this sort of program that's going to be coming through soon, I think is absolutely amazing, and how hopefully it'll roll out to type 2 and other types of diabetes, and even, like you say, other life conditions as well. I think it's so important. We've seen some comments in the chat to say, let's have a look. Rob says he used to lead the expert patient program when he lived in London. He learned so much from the participants, and great for his own well-being. You know what I mean? It's not only good for other people, but it does help us with our mental health and well-being. So that's lovely to see. I saw Philippa also say that there are also a lot of in-person sort of peer support groups where people meet up and go places, whether it's the park or somewhere to eat or drink. And I think it's great. And like you highlighted in your presentation, James, is that there are so many fantastic peer support groups out there, and it just shows, and they need that first and foremost, but it just shows the importance of it. And like you showed the principles, obviously you showed the QIC. It just shows and highlights how important peer support is, and I think this program is great. Will it be available for all? Will all centres develop their own sort of course, do you think, from this, or do you think Eden will roll this out? Is it going to be rolled out sort of nationally for everyone? What's the thoughts there?
So the plan will be that kind of anyone that's interested or using technology in type 1 diabetes will be able to sort of express their interest and take part in the program. There's no limitations on that at this moment in time, and the more the merrier, I would say, because as you know, with this group, it's hard to do it on your own, isn't it? And you need a team of people, and we say at least 2 people to kind of do a peer support is ideal, really. I mean, within my group itself, I've really only got myself, which I'm hoping to have more people involved, so then it takes a bit of pressure from myself. So no, the more the merrier for sure. And we're hoping that this acts, as I said before, this is like gives it a try, certainly for people with type 1, and then we hopefully can use the platform to then adapt it to other types of diabetes, because we want to bespoke it to each type, each condition, and make it really as personable to that individual condition. Because if we made it generalistic, it may not kind of stick as well. So that's why we want to make it more purposeful. And the reason why we did it is because, as it said in the NHS, said there's not enough of it. But it's one thing to, like, Joe blogs who's got this condition. I want to set up a peer support group where it's like, where can I go? What can I do? And some education programs I've seen, they sometimes cost as well. Some were free before, and there's not many around. So it's an opportunity, at least for some people.
That's brilliant. Thank you so much, James. Claire says, thanks, James. An interesting topic. I hope the project goes well. So yeah, keep an eye, guys. We will share on our social medias when more comes out from James and the team at Eden. But thanks, James. If there's any more questions, check it out in the chat box. But thanks for coming along.
Thank you.
Cheers. Thank you. All right, guys. What a fantastic evening we're having. Let's have a look at what our next guest speaker is. We have the amazing Amar Glab from the Leicester Diabetes Centre, and she's tonight going to be talking about some different research projects, quite a few actually, 4 or 5, and it might be something that you might want to get involved in or learn about. So let's bring up Amar to our screen. It's lovely to have her here tonight. Hello. Oh, you just need to unmute your microphone and then we are good to go. You tell we're live.
Good evening, everybody.
Hi.
How typical. Thank you very much for the opportunity to present here about the studies that me and my team are supporting at Leicester Diabetes Centre.
Brilliant. Over to you. Thank you.
Thank you. So here at Leicester, we have a diverse multi-ethnic population, which has one of the highest prevalence rates for diabetes in the UK. And we are here to help you and to keep you well. And we stay in touch with people with diabetes to keep them well and out of the hospital. Certainly, we are working in a different ways, speaking to patients via virtual clinics, video links, as well as seeing them face to face. We are here to continue to support you, and we have our website which you can visit, which has some useful tips on keeping healthy and well. We want to make sure that we increase knowledge and improve care for patients with diabetes through high quality education and research, so that we can learn from the research and apply it into the clinical practice. Essentially, we're trying to provide new answers for long-standing challenges through the world-class research. The Leicester Diabetes Centre is a clinical facility located. Oh, did my slide move? I'm not too sure. Oh, yes, I think it did. Beg your pardon. So this is a clinical facility located at the Leicester General Hospital, University Hospitals of Leicester. And we deliver here a wide range of research studies in diabetes that look at the areas of early detection, prevention, structure education, new therapies, along with teaching and training for both patients and health professionals. We are also interested in a lifestyle, diet, nutrition, activity and sleep, weight management, weight loss surgery, heart disease, including high blood pressure. Leicester Diabetes Centre is a national and international reputation for clinical care and clinical research, and our study results influence NHS local policies, Department of Health programs and NICE guidance. Your involvement really makes a huge difference to us, and here are some positive reasons about getting involved in our research. All research is performed to the highest standard, highest quality and ethical standards, and is routinely monitored. You may have access to the new education programs, best equipment, tests, treatment options available. You can gain information about your own health and well-being, generate interest in the current research and advancements, help others by contributing to medical research, have a say in a local policy and treatments available by sitting on ethics or patient groups, assist in improving patient care in NHS through clinical research and advances in medical knowledge. Most of our studies provide travel expenses, and for some studies, there's a compensation for your participation. So first study I'm going to talk about is MyFoot. This is a research study, a randomized controlled trial that tests a program that is designed to improve heart health in people with diabetes and diabetes-related foot ulcers. MyFoot program aims to help people to better manage the condition, receive most up-to-date care, and be more physically active. People who are age over 18, have type 2 diabetes diagnosis and current or previous diabetes foot ulcer can be involved in this trial. The study lasts 2 years and involves face-to-face visits to Leicester Diabetes Centre, completion of questionnaire, wearing an activity monitor to measure physical activity. Overall number of visits vary depending on whether or not you would be randomized to the intervention or control arm. Randomization is something that it's a little bit like a toss of a coin, where by you can either continue with the usual care or be offered the MyFoot program. So MyFoot program consists of a one-to-one session with a healthcare professional, group-based education with a gentle physical activity, and also we are offering access to an online platform designed to support patients to live healthy lifestyles. We provide reimbursements for time and participation, up to £60 for the participation in the entire trial, and also we are able to reimburse travel expenses. This is a national study, and there are several sites across the UK who are taking part in this study. And so if you meet the criteria or know someone who does, you can scan the QR code and register your interest, and we will be in touch. If you are interested in a research study that will test a new type of care that is been specifically designed for people with early onset adult diabetes, the M3 study might be for you. It's a research study that tests new type of care that has been specifically designed for people with early onset adult diabetes, aims to focus on the things that matter most to the person with diabetes, making sure that their care is tailored to their needs. In M3 healthcare, healthcare will be arranged and delivered in a way that suits your lifestyle and work, focuses on what is important to you, and uses technology where helpful. Again, this is a 2-year study, involves 5 face-to-face visits, 5 phone calls, and again, there's a provision of reimbursements for travel expenses and for participation in the study. The next study is DETA. DETA is a trial looking at the effects of exercise in combination with prescribed medication called dapagliflozin on physical health in those with type 2 diabetes and how these treatments compare to a modest diet. Being physically active and exercising help people with diabetes keep their muscles strong and functioning properly. However, not a lot is known about how these benefits combine with medications. And so if you are interested, the details are on this slide. The next study I'm going to talk about is called CODEC. This study recruits people with type 1 and type 2 diabetes. The main aim is to understand whether being a so-called night owl or an early bird has an impact on controlling blood sugar levels. Research shown that people who have later bedtimes, so-called night owls, are more likely to develop diabetes and other health problems such as heart disease. And this is still true even when those night owls get the same number of hours of sleep as early risers. And the underlying causes have not been clearly defined, but appear to be related to something called circadian misalignment. And this is where the societal pressures, such as work shifts, force us to wake earlier or stay awake longer than we naturally would. And so if you know anybody or you yourself meet the criteria, please scan the QR code to register an interest. The next study I'm going to talk about is called Freedom 2. And the aim of Freedom 2 is to see if a patient using a Freestyle Libre free device will improve a patient diabetes management over a 32-week period. If patient is not included to use the Freestyle Libre device in the initial part of the study, they will be given opportunity to use the device once they've completed their part in the study. This is a commercial study that has been promoted by the National Institute for Health and Care Research. Study tries to determine whether real-life glucose monitoring with Freestyle Libre device improves glucose control, which is monitored by change in HbA1c. And eligible participants would need to be on basal insulin. The study can be conducted completely remotely with REN services who have nurses who do home visits. And this is a national study, and there are several sites across the UK who are taking part in this study. And if participants prefer to do face-to-face visits, they can be directed to those centres for those visits. Stratus study wants to look at the effects of Freestyle Libre on quality of life and the effects of and its effects on the hospital admissions. Study is trying to assess whether using Freestyle Libre in combination with an increased regular contact with diabetes healthcare professional will reduce hospital admissions in people with your type of diabetes. It is a randomized controlled trial, which means there are 2 arms to the study: standard of care, which means that you would follow normal care as a diabetes patient, or a Freestyle Libre arm where you'll be given a device for monitoring. We don't have any influence on which arm you will be allocated, as it's a computer generated and is completely random. Most of the study can be done remotely, and we would need to come you would need to come to provide written consent when 6 months, and then come 6 months after to provide some blood samples. Other than that, a healthcare professional will contact you at regular intervals to check in with you. And if that is something that you'll be interested in, the contact for the research team is on the slide. Last study I'm going to talk about is called BARIEX study. This is looking at the effect of the steady 30-minute walk on blood sugar levels in individuals at least 1 year after the gastric bypass or sleeve gastrectomy bariatric procedure. Study comprises of 6 visits, a combination of face-to-face and telephone calls. Overall study commitment is 3 to 4 weeks, and face-to-face visit will take place at Leicester Diabetes Centre. There are reimbursements for the travel, £20 for people living outside of the Leicestershire region and £7 per visit for people living within the Leicestershire region. Before I'll ask for any questions, just want to say that we also do a number of questionnaire studies, meaning that we would be able to post questionnaire to the participant, and there's no need for anyone actually attending Leicester Diabetes at all. And so thank you very much for the opportunity to present here today, and for your time listening about the Leicester Diabetes Centre research. Thank you, Tom. Any questions?
Thank you so much, Agar, for coming on today and sharing all them fantastic research studies that are live and active and wanting people to get involved in it. And I think it's so important. Why do you think people should get involved? What is the benefit, do you think, of people participating in research? What would you say?
I think it's important to remember that today's research is tomorrow's care. And so to me, the most important part of research is that whatever we do today, tomorrow might become standard of care.
That is a very strong point, isn't it, to really think about. And I just think it's great that tonight we're hearing so many fantastic speakers sharing the research and active research that is available for people to maybe go have a look at. There's no pressure, and like you say, it's looking at tomorrow and the future, and people like ourselves who have got type 1 or have connections to diabetes. If you're happy to participate in these studies, it can potentially help the future. So I think it's really interesting, and I think tonight you covered different research, including weight and feet care and hypoglycemia, and I just think it's really fascinating. If anyone does have any questions for Agar, please put it in the chat box. Let's have a look. Love this run through trials, so often only hear of things by chance. You know what I mean? Absolutely, Philippa. That I didn't know anything about these trials until I saw tonight's presentation. So it's interesting, and I think we need to see more of it, and hopefully people will look at it, and if it's right for them, then yeah, brilliant. Thank you so much, Agar. We got a message from Claire. Thank you, Agar. So many research studies. We'll definitely be looking into them. And again, if you have any questions, please put them in the chat box. But thank you so much for dropping in tonight. All right. Let's have a look at our schedule for the remainder of the evening. And kind of highlighting back really of tonight's fantastic chat, we have had 5 fantastic speakers that have shared their research. Next up is Rachel Hicks, who is from Australia. Unfortunately, I don't know if we're able to connect up with Dr. Rebecca Thomas. She's away with work at the minute, and I'm not sure if some technical difficulties or things like that, we can't get Rebecca. But when we can connect up with Rebecca, we will post the video out on our social medias and YouTube so that you guys can see her fantastic research in eye screening and health. So that's really important. And when we get that, we'll for sure share that. So let's have a look. Our final guest speaker. Let's just check in with Rachel. I can see her off screen. Rachel, are you okay to go? Thumbs up. All good. Oh, good. Okay, so our final guest speaker is Rachel Hicks, joining us from Australia. She is a person who's living with diabetes. She's a mother of 2, and she is a PhD candidate researching lived experiences of diabetes and pregnancy, focusing on community-led projects. Her research career objective is to assist as many women with diabetes to have a successful pregnancy journey. And I think that's so important. And we've had sort of mini chats on Diabetes Chat about this. And tonight we're going to hear from Rachel, who's going to be able to share much more with us. So, hello, Rachel. Good morning to you over in Australia. It is. What time is it there with you?
It is almost 9 a.m. Good morning from sunny Sydney, Australia. We
Wow.
are here.
Brilliant. It's lovely to have you. And that's what is great, to do events like this where we connect with people from literally all over the world, and we're literally connecting with you over Wi-Fi and signals and all that. So it's great to have you. I will bring your slides to the screen, and if anyone has any questions for Rachel, please pop them in the chat box or hashtag diabetes chat, or any comments, and we'll get that to Rachel. Over to you, Rach. Thank you so much.
Wonderful. Thank you so much, and thank you for the opportunity to present and have a chat today. And I will disclose, I literally just had a hypo. So if I have any brain fog, I do apologize, but I've loaded up on some sugar, so let's see how we go. So first thing first, I would like to acknowledge and show my respects to the traditional custodians of the land. So here where I am based, our Australian Indigenous local communities are the Gundungurra and Dharawal people, and I want to really acknowledge and pay my respects to them on the land at which I work, live, and do my research. So, thank you again so much for the opportunity to present and chat today. I am so excited to be a part of this. And my slides are probably going to be a bit of a story rather than giving heaps of research information, just because I am a bit of a baby researcher. So, first thing first, why diabetes research? So I am coming up to having type 1 diabetes for almost 29 years now. And I remember when I was first diagnosed, there was discussion around the ability to become pregnant and have children that was at the time quite negative. So fast forward after years of having diabetes distress and things like that, and I got to a stage where I was with such an important, supportive and empowering diabetes team that I was able to successfully have my 2 lovely children, and this included having access to a really great pre-pregnancy care program and also diabetes peer support. It's kind of interesting. For a long time, I kind of denied having diabetes and seeking out support, and it really wasn't until I had my son, my firstborn, that I realized, oh my gosh, I have no idea of what I'm doing. And I reached out and I found incredible peer support communities through Twitter and through Facebook, especially in the context of diabetes, pregnancy, and beyond. So it really, really helped me get through. Academically, I am a social scientist. I specialized in qualitative research, and I have a background in marketing, communications, and journalism. So how did I end up in research? Well, both of my births were, whilst the diabetes care was great, they were still quite traumatic, and the support I got postpartum or even during my hospital stay was not great. And it was through the diabetes communities and peer support, including co-hosting a podcast in Australia, which was with fellow women with diabetes that I met through peer support, that I started to realize and hear the lived experiences of others that had not had great journeys to becoming pregnant and giving birth, and they didn't have supportive diabetes teams. And it kind of made me thought, I really want to do something about this. What can I do? And the opportunity came up to do a PhD. So on maternity leave, I decided to apply and start doing this PhD that examines those lived experiences of diabetes and pregnancy. And yeah, my research goals are helping as many women with diabetes, of all types of diabetes, have an empowered, healthy pregnancy journey, but also improve communication and collaboration between healthcare professionals and community so that we are getting those better health outcomes. So I kind of call myself a middle woman between the community and between the healthcare professionals for a lot of my projects at this stage. So I will go into detail on this, but basically at this stage, I'm a baby researcher. I'm in the middle of trying to get some publications out there, and I really have 4 projects because my PhD is by publication. So I'll go through the 4 papers that I'm focusing on now. This is just briefly what they're on about, but I'll go into more detail on the next slides. So firstly, I conducted a systematic literature review to have a look at what was out there in terms of lived experiences in the context of pre-pregnancy care for women with pre-existing diabetes. And what I was looking at was the scope of consumer and community involvement or lived experience involvement for women with pre-existing diabetes in developing these pre-pregnancy care interventions and projects. And the objective was then to develop a set of recommendations for healthcare professionals moving forward on a framework that focuses on lived experiences and community lead and community design in developing these projects to increase pre-pregnancy care engagement and looking at effective contraception for those who don't want to go along that path yet. Now, from the studies, the most common themes that came out, which I'm sure the community here would be quite familiar with, is the main barriers to accessing pre-pregnancy care include negativity and stigma in care from behaviours and attitudes presented from healthcare professionals. Also, the frequency of appointments being a huge barrier around existing work and life commitments, because a lot of women felt that their pregnancies became so medicalized and just having to be at hospital almost every single day in some parts was just too difficult to navigate. A lot of women, again, with that medicalized focus on pregnancy, were so concerned about losing a normal pregnancy journey, which is just so sad. And there's a lot of talk about risks and challenges and things related to pregnancy planning with diabetes. And research has showed that the majority of women with pre-existing diabetes are aware of this. But if they have a really well-established relationship and trust with their healthcare professionals, it is something that they're more open for discussion with. Where I'm from in southwestern Sydney, we have a very large culturally and linguistically diverse community here. And a lot of the information about pre-pregnancy care and contraception, it's just not easily accessible in forms that would be of most benefit to these communities as well. And a huge focus in the research as well is that there's a lot of digital support methods out there for pre-pregnancy care that a lot of our healthcare professionals and clinics aren't aware of. So we're looking at peer support, we're looking at social media, things that we're very, very aware of here, but there's just a lack of knowledge in the professional clinical service environment of what is out there. So in summary, this is kind of where all my research is focused right now. My framework, what I've included in there is that community needs to be active stakeholders for the entire components of projects. And there needs to be active representation of lived experience and knowledge contributions, but also compensation as well, especially around the transitional stage of life that is pregnancy and giving birth and beyond. Academically, it's been shown that this is a time when it can be a big hit to finances for a family. So it's so important for our women with lived experiences being a part of these projects to be compensated as well. And then their acknowledgement of their lived experiences being so important in these projects. A big recommendation I have here as well is around improved communication methods, such as empowering language and messages. So we're very familiar with the Language Matters campaign. In Australia, where we are trying to bring this more into the table regarding pregnancy. I know there's some fantastic initiatives in the UK right now being set up, and we're trying to do similar here because it is, in the context of pregnancy, it is something that is a bit of a challenge here in Australia at the moment. We are also looking at earlier information and better accessibility on contraception options, including linkage with transitional clinics or primary care as well, and looking at other options we can use to deliver this information, especially for our culturally linguistically diverse audiences. We're also looking at prioritising digital methods for projects with apps and podcasts and peer support recommendations being embedded into projects as well. So there's more knowledge from the front line for our healthcare professionals on these. And lastly, of course, we're encouraging for all of our projects moving forward to have peer support and social media integration, as mentioned earlier, but looking at formalized linkages with these communities that have been created by the community for the community. And we know how extremely valuable this is as a mean to obtain perspectives and lived experiences. So moving on, so I also have another paper where I'm doing a thematic analysis of discourse in a community-led online peer support program. So locally, we have a pre-pregnancy care program that's been running for a long time, but it hasn't really been audited from the perspectives of the women with diabetes. So there was an initial peer support social media group set up by the organisation and then handed over to those with lived experience. And we're going to be using this space to see what feedback the women with lived experiences can provide on the current services, what they would like to improve, and then report that back to the healthcare professionals as well. So we're looking to see if this will help increase engagement with those trying to link in with those services, and also proposing an ethical framework to assist with considerations in private spaces of peer support, which is a big discussion point at the moment with trying to set up projects around peer support that link to healthcare here in our local area at the moment. This is kind of all in progress, this one, because we're trying to look at doing some additional recruitment at this stage. So I've also got a mixed methods pilot study. So this project, we're looking at making a resource for healthcare professionals. It's going to be a video on appropriate communication methods, and it's all around the context of planning pregnancy and best communication regarding challenges, benefits, and also looking at empowering women to make choices around technology that will help them with the pregnancy journey, whether that's looking at diabetes devices, whether that's looking at peer support or apps, technology as a whole. And this is in progress at the moment as well. We're actually in the stage of starting to develop the resource and then take it to our lived experience community to see what they would like to add before we start filming and adding some more in there. But it's really, definitely we're going to be taking things from the Language Matters campaign, of course, to see if we can bring this, especially to our primary care networks, where a lot of our local women have identified that there is quite an issue around the language used and how it sort of it makes them feel stigmatized as well. So this is another work in progress. And then this is probably my most current work that I'm doing as well. So I have a project that's specifically around gestational diabetes. And the reason for this is within academia at the moment, there's this ongoing discussion about gestational diabetes and what should we use for diagnosis? What should be the criteria? Should it be 1 or 2 step testing? And all this other debate that's happening around gestational diabetes. And it's being debated with diabetes academics, healthcare professionals and things as well. But I went to my supervisory team and I said, well, what about the women with lived experience with gestational diabetes? What are their thoughts on this? And they said, good point. And I said, let's do a project and let's approach the women. So this is a global project I'm on at the moment where I am examining from the community perspective, what is their preference regarding gestational diabetes? What do they think about the criteria for diagnosing gestational diabetes? What do they want for testing and screening methods? And then what would they like to see for support from healthcare services once they're diagnosed and beyond? The main findings for this so far, we currently have, I'm in the middle of doing analysis from focus groups from all of the main continents at this stage. But we're finding, of course, gestational diabetes is an emotional roller coaster. It's a lot of information to take in. I really feel for the women that get this diagnosis as well. And women state that earlier diagnosis might be easier for them to internalize and to manage long term. And overall, there is a preference to doing a one-step test and shorter testing with an agreed criteria. Basically, the women were saying, a lot of them were saying, we don't really care what the criteria is as long as there's an international consensus on what it is, because women were going through multiple pregnancies and the criteria was changing between it. And it was just so confusing. Again, empowered communication is very important. The removal of stigma, blame, and guilt was highly emphasized by all that we interviewed as well as improved engagement with primary care. A lot of the women were saying that they had such established trust with their local healthcare professionals, such as their GPs, but once they got a GDM diagnosis, they were forced to go to these large hospitals away from that community of support that they knew. So they were suddenly forced into this very medicalized pregnancy with a team they were unfamiliar with, and they felt like they really lost the support that they needed to go through that pregnancy. So yeah, this is a project I'm in the middle of doing at this stage. So that's basically my research at this stage. I am a baby researcher, as I said. Everything's kind of up in progress or in the middle of trying to get published. So I hope I can share more outcomes with you soon. But I wanted to basically, in summary, just say what's next and also recommendations if you're someone with diabetes that's thinking about going into research as well. So I'm hoping to finish my PhD in the next 2 years if all goes to plan, just waiting to see when things can get published. But I really do have a plan in mind. I really want to do a postdoc project, which is a bit of a passion project of mine based on my lived experience. As I've said, I did have a very rough time postpartum, and I felt like I didn't get much support as someone with diabetes. So I really want to look at a project that improves postpartum care for women with pre-existing diabetes here in Australia. So that's the plan. We'll see how we go. I've got to finish the PhD first. But if you're someone interested in research, especially if you're in a transitional stage of life, such as pregnancy, birth, and beyond, I would say really think about how it's going to impact your life, including diabetes, because you'll be looking, it can be quite confronting sometimes seeing the research that is out there. And even sometimes I might have to step back from presentations that I see at conferences or similar just based on things they're discussing. So there might be neonatal outcomes they're looking at, and it kind of takes me straight back to when I was in ICU with my 2 kids, and I just have to kind of separate myself and, step back and, just kind of protect myself as part of that. If you have family commitments, it's something to consider when you're thinking about it as well. I would say it's impossible to do research if you don't have a supportive team, a supportive supervisory team that understands the commitments you have, as well as the importance of taking care of your own health, diabetes and mental health as well. What can happen a lot as well is if you're asked to be a lived experience representative on projects, I am very passionate about seeking compensation for your time as someone with lived experience, because you are just as valid having a spot on that table as any of the other people who are part of that team, regardless of academic experience or things as well. Also, as part of that, determine if you're the best fit for the project and if there's someone else in the community that you know of that might be more suitable to be part of it as well. But super, super, super important as well. Just be wary of burnout, especially if you have experienced diabetes distress, or I go through times of having autopilot with my diabetes. Thankfully, I've got auto mode, so it makes it a little bit okay to manage. But it's super important to remember, because a lot of your research will imitate your lived experience, and just make sure that you've got support and seek assistance as you need. But otherwise, thank you so much. I have to thank the community for their support, as well as my university and organizations who've provided me with support to make me be able to continue my research. If you have any questions, please feel free to reach out to me. I need to start using Twitter better. Now my kids are a bit older, but I'm happy to have a chat with anyone. And thanks for the opportunity to present today.
Wow, Rachel, that was absolutely fantastic. And I've put down here baby researcher, but my goodness, Rachel, you are absolutely sensational. The amount of work that you're putting into this, and I just think it really truly ends our fantastic evening. I think that we need people just like you, equally to the researchers or healthcare professionals that we've had tonight, who may have more experience. Hey, but we need people exactly just like you. And when I spoke to Belinda Moore a couple of weeks ago, and she said, look, I think this can be a great event, and she was looking at people who she could get in contact with, and she reached us up to connect, didn't she? And I just think it's been wonderful working with you offline, and just hearing the presentation tonight is really, really fantastic. And let's have a look. Some questions here. Rachel, are you also looking at the post-birth? Obviously, you mentioned that in your last slide. Was there anything you wanted to add on that?
Yeah, no, absolutely. It's here. I have to admit, seeing some of the support services that are available overseas, especially in the UK and in countries such as Sweden, I'm a little bit envious here in Australia, because here we kind of go from having, I had sort of almost appointments every single day up to delivery at the end. And then once the baby's out, everyone kind of goes, all right, see you. We'll see you in a couple of months. And you go, well, hold on. It's like, it's a massive adjustment. You go from having daily checkups to, oh yeah, see you in a couple of months. You've got this. And for me, it was just, that was when I needed peer support. And that was the only way I got through that time frame, because I was dealing with sensors that were dodgy and, you know, just trying to navigate feeding my baby and running on lack of sleep, and my levels just not really balancing out. And that was the time I really needed the most support.
What support do you think you needed?
Yeah.
Reflecting back now, what did you need that you didn't have, or what do you think needs to be in place going forward?
So I think there needs to be access to healthcare professionals outside of your standard business hours, because it was kind of at night when I was struggling going hypo, and I couldn't contact my treating team because, you know, it was just a 9 to 5 thing. I could send emails, I could send texts, but no one really got back to me until the start of the workday. But at the same time, I think just having better referrals to additional support, so mental health support, or even, I guess, antenatal support like lactation consultants and things like that needed to be more readily available. But it wasn't. I found I was really scrambling, and it wasn't. I think if I didn't have the diabetes community support I would have just been absolutely lost.
Yeah, and you can see people send the messages. Anna, that was amazing.
Oh, thank you.
Flipper says sounds the same in the UK as well, to be honest.
Okay, yeah.
Claire, thank you, Rachel. And, you know, I think you've got a valid point that you are going through pregnancy, you've got type 1 or a type of diabetes someone might have, and you're having all this support or extra support in the lead up of having a baby, and then, like having a baby and then seeing in a few months. I think that's hard, isn't it? Because if you've had all that support before, you still need it after. So, you know what I mean? I think there's a gap there that needs to be, the bridge needs to come closer, and the care has to be provided. Let's have a look. Loving Rachel's advice for people with diabetes, so valid.
Oh, thanks, Flipper.
Linda, I agree. There you go. You can see, can't you? You can see, and that's why we've had these discussions on Diabetes Chat. But tonight we've seen it with the research and what people are saying. But it's interesting to see, isn't it? And also Flipper says that as well.
Yeah. That's quite a common one we're finding, actually, is that, the women with gestational diabetes are finding, a couple of the women I've interviewed have said they've actually reached out to colleagues or friends they know that have had pre-existing diabetes to find out, like, how on earth do I use this tech? They're kind of given, the women are given the tech and then kind of left to their own devices to figure out. And I mean, I've had friends diagnosed with gestational diabetes, and they've kind of reached out to me to go, how the hell do I test? How the hell do I do this? And I'm like, okay, let's see what we can do. But absolutely valid point there.
But the care should be there, shouldn't it? You should know what you need to do. You should walk out that door feeling confident. And if you don't feel confident, then you have another chat. You have another appointment until you feel safe, isn't it? So brilliant. I think that's most of the questions. Just check with Instagram. Brilliant. Thank you so much, Rachel, and especially for connecting with us all the way from Australia at this early hour. Thank you so much. And you need to get your podcast back. I think you're a natural speaker, and I think you're such a advocate, especially in this field and pregnancy, and I think you should do more to connect with people. And obviously, there's a lot of things happening in the UK now with sort of the movements with Language Matters, and I think there's one to do with the pregnancy. So
Yeah,
you know what I mean, like
Nikki, that looks fantastic.
Nikki. Yeah. So you know what I mean. I think it's great, and thank you for coming on tonight and sharing your amazing research.
No worries. Thank you so much for the opportunity. Thank you.
Cheers. Thank you. All right, guys. All right. Wow, what a fantastic evening it has been this evening, hosting our research event. We have had our incredible speakers. We started at 8 o'clock and we introduced tonight speaking to Stephen and Kes, and they shared their lived experiences of participating in diabetes research, what research they were involved in. Then we had Dr. Amar Puttanna, who talked about dementia and frailty, and that was really interesting. And so please go check that back out. Tom Crabtree came on and spoke about the hybrid closed loop pilot study that he was part of a couple of years ago, and was heavily involved in that study, and has really shaped where we are at in the UK, particularly with where hybrid closed loop is going with the TA guidance. And it's really interesting to see some of the statistics there. And let me just go back to my notes. One of the statistics was a 27.8 percentage of time in range increased due to the participation of the study in part of the hybrid closed loop, but also 95% improvement of quality of life. So 95% of the participants were saying it was improving their quality of life, which is absolutely fantastic. Lauren Quinn stopped by and talked about the ELSA study, which is a UK program and is for children 3 to 13, a screening process. And it was interesting to learn more about that. So if you want to go check out the ELSA study, then please do. James also spoke about peer support and the importance of peer support, and the champion program that the Eden Diabetes Centre are looking at funding and starting very, very soon. So we all see the importance of peer support, and there's so many fantastic peer support communities out there. But this will be a really, really interesting project to get involved in. So contact James if you're interested. Agar stopped by and talked about the different research projects at Leicester Diabetes Centre, and we saw comments coming through from Philippa and some other people saying it was interesting to see all these amazing studies because we don't know about it, we don't see it. So actually there was like 6 or 7 that you could actually, oh, that was interesting, or I want to find out more information about that. So you can go check it out on our recording. And then Rachel just finished a fantastic evening highlighting her amazing advocacy work in pregnancy, and we'll be definitely seeing more of Rachel, I'm sure. Unfortunately, Rebecca couldn't make this evening. She is away with work in Dar. She's tried to send the video across, but we haven't been able to get it yet. So we we'll keep it. Once we get it, we'll upload it, and then you guys will be able to see that on iScreening and Health, and she will share that with you guys. Okay. Last few bits from me is check us out on Twitter, our social media at diabetes_chat, and you can see all our weekly Twitter spaces. We'll be back there next week for that. We did a special event this week for this, and I hope that you found it useful seeing the sort of speakers come on and see the visuals and the slides, and I thought it was really fascinating to see that. Instagram, we're on there as well, Diabetes Chat. Check us out there. YouTube, search #Diabetes Chat, and you'll be able to see all our podcast episodes with our guest speakers, including this, which will be live immediately on the YouTube channel. And of course, our website, diabeteschat.net. Check us out on there. You can see all the podcasts. You can see our Thursday threads. You can see polls. You can see lots of interaction videos, and hopefully that will help you. And as we say, we're a peer support community, so we share experiences and we talk and we connect with people all around the world. And we recommend that you take away maybe something from tonight and go speak to your diabetes team, and they'll assist you further with the next steps going forward. So if it's something you're interested in, please go speak to your diabetes team, and they will, I hope, be able to support you with that. All right, last bit from me is what's coming up for Diabetes Chat over the next couple of weeks. Back on our Twitter Spaces. We'll also be on YouTube streaming, but we'll be on our primarily Twitter Spaces like we're normally on. Next week, we have Professor Nick Oliver, and he will be joined by our host, Philippa. And then we'll end the month with that open forum chat where we can connect, talk, share, and the agenda is completely yours. So you can talk about anything you want regarding diabetes. And then next month we have Dr. Thomas Griffin be talking about connected pens. We have a type 2 chat with Ken and Helga, and then Ginger Vieira will be stopping by, and I believe it was on food, diabetes and food. So we'll see. I think that was the agenda. We'll be excited to see that. And then again, open forum at the end of each month. So that is it from me. I hope that you have enjoyed tonight's chat. I hope that you have found it useful, and go back, watch it back at your own convenience. We'll put timestamps on so you can see each individual episode, and we hope that you have taken away something from tonight. And I think it showcases the importance of diabetes research. We see these amazing people that have come on tonight to share their time with the community, who are doing these research projects, and there's not just them, they've got a team behind them and lots of people who are supporting with the research. But it's also, like we talked about before, it's us people living with diabetes or have connections to diabetes, whether it's a parent or carer. And it's interesting to hear these studies. And if it's something that we want to get involved with, then please reach out to the individual researchers, and they will help with any questions that you have. I think I just see if there was any other comments. Philippa says, thank you all who gave their time and participated. It is so appreciated by the community. Absolutely is, isn't it? We're a voluntary community, and it's great that we've had the opportunity to have these healthcare professionals and people working in diabetes, PhD students, to come on and share the research. Absolutely amazing. Let's have a look. What brilliant guest tonight. Such a resource for the future as well. 100% that you can go check it out on our YouTube straight away. It'll be on our website in the next couple of days, and yeah, go check it out. Claire says, wow, so much information shared. Absolutely, we've been talking over 2.5 hours. So yeah, absolutely amazing. So that is it from me. Thank you so much. It's been really, really cool. Tony says, let's throw it up. Been dipping out some amazing content. Absolutely amazing. So thank you so much. Have a lovely rest of your evening, whatever you're up to. I know I can see Rachel in the background. It is 10:30 in Australia, so I'm sure she'll enjoy the rest of her day over there. But from me, the Diabetes Chat team, thank you so much for your time tonight. And check us out on Twitter and all our social medias. And we will see you very, very soon. Take care, guys.